So now I hope everyone's excited. We're going to talk a little bit more about the chemistry behind all of this and focus in on our safety of our PN therapy, so nutrient integrity and compatibility as well. So here are some objectives that we'll cover in this part of the talk. We'll dive right on in to nutrient stability, which is, I know, everyone's favorite topic. So there are a bunch of different common disruptors. What could possibly go wrong when you mix a bunch of different things together into a bag? There are a few that kind of stand out as potential more common disruptors. You can have a salting out effect with really high concentrations of cations and anions, where you end up depriving all of your other molecules in your solution of adequate water to remain dissolved. You can have high concentrations of dextrose and amino acids that really help you with your calcium and phos ratios, but also can be easily disrupted in terms of adverse environmental or chemical environmental changes. So if you Y-site something in accidentally that is more basic, you could end up with a precipitate in your line. Focusing a little bit more on calcium and phos precipitate, we see those that can be affected by 100 different things: temperature, pH, how you mix the PN itself, medication co-administration, the ratios, magnesium, you name it, it probably impacts your calcium and phos ratios. So as we change our pH, we get a lot of benefits, but also a lot of risks. So the more acidic you make your PN bag, the better solubility you have for calcium and phos. You also have a little bit better integrity for your ascorbic acid, but you lose the benefit of the stability from your fat emulsion and also for some of your trace minerals. So copper, folic acid, those can all be affected by reducing your pH to a more basic level. Phosphate is sort of an age-old problem in PN in general. We know we need to give it. We need to give it in pretty high quantities to achieve somewhere close to in utero accretion for our preterm infants, but it takes different forms at different pHs, which is what makes this really fun to try to navigate. In your most acidic environments, you have monovalent phosphate predominating, which is great because that is the most soluble form. It usually stays in solution even when it complexes with calcium. At moderate pHs, you get dibasic phosphate, and that's where you start to see things starting to precipitate out into your lines. And in your most alkaline environments, you can see trivalent phosphate. This is a lot less likely to see in a PN situation where you're dealing with fairly acidic components. But if you were to Y-site something in accidentally that has a very low or a very high pH, something like epoprostenol, that diluent is pH of 12. So if you accidentally run that in with your line, you could see a trivalent phosphate predominant. It all stems from organic versus inorganic salts. So phosphate specifically has two different forms that are available kind of internationally, and it looks different everywhere you are. And so that creates a little bit of a challenge for us to interpret information, and as we talk about compatibilities, this will come back into play as well. In Europe, sodium glycerophosphate is available. That is an organic form of phosphate, and it's covalently bound to a glycerol backbone, and it prevents the precipitate forming with calcium. In Canada, they have a monobasic potassium phosphate available, which is inorganic, but it is the more soluble form, like we talked about in the slide before. And then in the US, the only options we have are a kind of combination product of both mono and dibasic phosphates that's complex with either sodium or potassium, but that creates a lot of issues for us from a calcium and phos solubility perspective in the US specifically. I think this is a fun slide just to show you what calcium and phos precipitate can look like. This was when we were testing out a scanning electron microscope to see if we could use it for some compatibility research. And what we found was a lot of calcium phosphate on this plate. The tectonic plate looking things are when it dries, and then those little pom-pom items are the spherule form, which is generally present in native solution. So just something for your reference if you're interested in what this looks like. There are a bunch of different additives, like we talked about, that you can add to a PN that can destabilize it. Intralipid or IV lipid emulsions are one of the big ones. It really depends on the blend of oils used in the IV lipid emulsion itself as to what your compatibility looks like. Iron, another problem. We try not to add this to PN. It can be a risk, but definitely can impact both your calcium and your phosphate ratios, and then also can impact the zeta potential of your IV lipid emulsions. Multivitamin is generally thought to be one of probably the least stable items in a PN, and this can be oxidized, it can be affected by light, it can be affected by pH, you name it, your multivite's probably going to degrade. Trace minerals and medications are two other things that as you add them to your PN, you can see a lot of issues occur. In terms of osmolarity, the higher concentration that you add to anything, you're going to cause potentially more problems, especially when you're adding in something like an IV lipid emulsion. So amino acids, dextrose, and electrolytes all play a role here. The zeta potential of IV lipid emulsions is important to consider when you are talking about osmolarity and its impacts. So the zeta potential is a negative charge that is created by the emulsifier that keeps the lipid particles separated. As you start to negate the zeta potential with high concentrations of cations, anions, divalent cations, trivalent cations, and increasing pH or lowering your pH, you can see the zeta potential neutralizing and those fat globules starting to coalesce. All right, so does anyone know which environmental exposure does not cause nutrient degradation? This should be a fairly easy one. It's early. Tried to make these guys not too hard. All right, I think we've got a leading winner here coming out, and you guys are correct. Humidity changes don't technically cause nutrient degradation. All right, so we will talk about some environmental issues now. Impact of light is the first one. Photooxidation is exceptionally common and can happen at every single stage of your PN development. So preparation, storage, administration, you name it, light gets in and light causes problems. This can be potentially impacted by both UV light and artificial light, which makes it really fun to try to figure out how you light protect everything. But we know we need to. So there are studies that show that complete photoprotection reduced the rate of peroxide generation by 44% compared to partial photoprotection. And that also increases the degradation of your ascorbic acid. So it is an important thing for us to think about, especially when we talk about a high-risk population like a neonate, where all of the different oxidative stress components play big roles in our disease states, NEC, ROP, you name it. We think oxidative stress is implicated in a lot of these things. So thinking through how we reduce anything that's going into our patients and causing increases in oxidative stress is critical. ASPEN takes a position on this as well and recommends that complete photoprotection is more effective than partial. So this involves both photoprotecting your container and your lines. This is a manual process often. Those lines don't really come in photoprotected options very often, especially in a neonatal setting. And so you're often having to cover those with light protected tubing sheaths or aluminum foil, things like that. We'll move on to oxygen. Oxygen also creates a lot of issues. It increases our risk of degradation of both lipids and a bunch of other things, vitamin E, riboflavin, thiamine, ascorbic acid, amino acids. So again, oxygen causing a lot of problems for us in the long run. We can reduce the risk, and so our lipids are manufactured in containers that have a light absorber or an oxygen absorber in the packaging. And so that is definitely helpful, but once you pull it out of the packaging, then you're also back at stage 0 here. Your glass versus plastic containers. So plastic has a higher oxygen permeability than glass, and multi-layer bags have been proposed as a potential option to reduce some of that. But if you're using glass, then you lose some of the benefits of transportability and safety, things like that as well. And then finally, your compounding strategy. So as your PN is being compounded, that's definitely something that trying to reduce the introduction of oxygen at every point that you possibly can. The last environmental stability risk we'll talk about is temperature. This is, I think, fairly relevant in pediatrics, especially as you look at a NICU population. Anytime you are changing the temperature and increasing it, your ions are going to move faster and things are going to bind together faster. So lipid peroxidation and calcium phos can be impacted by temperature and can be fairly significant. And as your line Y's in through your warmer into your patient, what happens? Your temperature of your solution heats up and causes increased risk of precipitation. All right, so now we're going to pivot a little bit and go into compatibility basics, which is my favorite topic, but bear with me here. If you guys get bored, I'm sorry. So there are two different things you have to think about when you're talking about medication compatibility. Physical and chemical compatibilities both play in. A lot of our medications on the market are weak acids and weak bases, so they're high risk of different acid and base reactions over time. And what we have to think about is from a physical compatibility perspective, precipitation, color change, gas, evolution, and alterations in your pH. So this is multiple meds being added to a bag, things like that. Chemical compatibility is a little more nuanced and a little bit harder to study. And these are your basic redox reactions, hydrolysis, things like that. What basically ends up happening for chemical compatibility is you break down the drug itself. So you don't have the same effect from your drug, you don't have the same potency from your drug. So still a reality of risk, but definitely something that should be taken into account if you have the data. All right, so do any of you guys know what governing body dictates the regulations for particle counts in commercially available IV aqueous medications and IV lipid emulsions? Okay, we've got a winner here too. USP is correct. All right, so compatibility testing is focused at least in the US, around USP 788. This is looking at particulate matter in injections. So this is for aqueous medications, and it is the only thing that is available out there that dictates how many particles a manufacturer can have in a container. It's a manufacturing standard. There are two different methods associated with USP 788. Method 1, which is light obscuration particle counting. Method 2, which is microscopic particle counting. So the microscopic one is where you take this slide and you put it on a microscope and you count manually how many of all of those different size dots are on your plate. As you might imagine, this is probably fairly error prone. I am not a skilled microscopy person, so this is definitely something that is challenging. This is actually why we were trying out that scanning electron microscope that I showed you that picture from earlier, to try to get around having to do this. USP 788 has parenteral particle thresholds for both small and large volume containers. You can have a 10 mil container or a 99 mil container. No one would ever make that, but if they did, that has up to 6,000 particles greater than or equal to 10,000 or 10 microns in size. As soon as you get above 100 mils, your container thresholds are held to a particle per mil standard. So that is where a 101 mil container could have 2,525 particles greater than 10 micron, where your 99 mil could have 6,000. Go figure, right? I mean, it's very hard to apply this when you're taking partial doses out of vials and administering them to your patients, and you may have one thing coming out of a large volume bag, one thing coming out of a vial. It's really a difficult thing to apply without the denominator there. So as we talk about the studies that we've done, we have applied the large volume particle counts to all of our compatibility testing in an effort to kind of have a standard approach, but know that that is also not supported specifically by USP. When we talk about compatibility with IV lipid emulsions, it gets a little more convoluted. We talked about lipids being easily destabilized. Acidic environments can do it, high concentrations of calcium, magnesium, aluminum, you name it. And then that neutralization of that zeta potential, or those repulsive electrostatic forces, are what we really care about. Fat droplets begin to coalesce, leading to increasing fat droplet size. This is USP 729's recommendations for how to assess lipid emulsions. There are two different methods here. Method 1 is a semi-quantitative method. That is your mean droplet size, and that's that dotted line in the middle of the bell curve there. Method 2 is the PFAT5, which is a volume-weighted percent of particles greater than 5 microns in size in solution. So that is the red tail at the end of that graph. PFAT5 is the only metric in USP 729 that's validated in both animal and human subjects, and it's been tested in both IV lipid emulsion from the manufacturer and also from a TNA standpoint from a compounder. USP uses a threshold of 0.05%. We don't really know where that threshold came from, but it's a manufacturing threshold, and it's not well defined how to apply that to an extemporaneously prepared PN. Driscoll and colleagues studied this a bunch, and they came up with 0.4%, which is tenfold higher, essentially, as the potential critical value where you start to see unstable TNAs. And it's defined as the threshold where you may see a pathologic change in both the lung and liver of animal models specifically. There's also some data out there that supports 0.1%. So the application of PFAT5, while useful, is a little bit convoluted, and we don't really know which threshold we should be using. So that brings us to our special populations. We know that lipid coalescence has consequences. Our pulmonary capillaries are a diameter of 4 to 9 microns in size. So you can imagine in a baby who already doesn't clear lipids very well, which I think Cami will talk about, that we have a high risk of accumulation of those larger particles potentially in their lung capillaries, and that can look like a pulmonary emboli. There are reports that suggest a link between very low birth weight infants and pulmonary distress and IV fat accumulation related to IV lipid emulsions. So definitely something worth considering in our patients and something we should be cautious about. Additionally, there's some immune consequences where the macrophages get tricked by those large volume or large particles and stop looking for bacteria and start looking for lipids instead. So we don't really want that either. So we filter things. We know that that's the gold standard. ASPEN comes out and says you need to run all of your PN and your lipids through a 1.2 micron filter, which is great in practice. However, a lot of our patients are seeing medications run after the filter and sit together in those lines for long periods of time before they mix into the bloodstream. So the filter helps, but it does not reduce our risk of potential particulate formation downstream of the filter. An interesting study was done in a NICU setting looking at inline dynamic image analysis for particulate infusion during a kind of simulated NICU stay, and lipids were not evaluated. The product, the PN, had an organic phosphate form, which should have hopefully been more stable. But what they showed was 85,000 subvisible particles per day for our NICU babies are possible. And you see peaks during boluses of medications and particulate greater than 10 microns in size. Again, 4 to 9 microns is your pulmonary capillaries, doubled from the base solution to the co-infusion. So drug incompatibilities are a very real risk for our patients. This is how they set up that study. I think it's a great way to depict this. They have the PN bag, they've got a quad fuse with a bunch of different things running in through a syringe pump, and then they've got this particle analyzer at the end. And you can see over that 24-hour period, you see spikes of particle counts going into your patients. That's when they are running intermittent meds, caffeine, hydrocortisone, fluconazole, all of those things running into that line with a continuous infusion of dopamine also shows up as bumping your particle counts over time. So we know our babies are high risk. Their very low birth weight increases their risk further. We have a high likelihood of longer term PN requirements in these patients, and they have the small pulmonary capillary diameter that is probably even smaller than what is published currently. They have limited access. We're trying to preserve access. They often don't have great veins. You have probably 1 or 2 sites where you can actually get good central access. And then we need to concentrate things down as far as we can to provide as much nutritionally impactful fluid as possible. So your medications may be running in at a rate of 0.1 mil an hour or even sometimes less. And they can sit together with PN for long periods of time in those lines. So when you're assessing med compatibility, you have to think of a variety of different things. Where is your inline filter in relation to your Y site? And how much more time are things going to spend in the dead space between where your IV filter is and where it hits the bloodstream? You have to think about what testing was done and if it was done with equivalent or more concentrated medications. This includes all things in your PN matrix as well. The quality and methodology of published results is widely variable. I think we all are aware of that. And I think that there's no internationally agreed upon standards. So we have to interpret these with a lens of thinking through what your patient looks like and do it from a patient-specific basis. And then finally, a risk-benefit assessment. You have access needs, you know that you're going to have future needs, you have risks associated with every single line you get. So these are not benign things, but you have to deliver critical medications and critical nutrition. So it's definitely a convoluted approach. I'm sure many of you in this audience have been on the receiving end of a phone call asking about a compatibility. And when you say, oh, there's no data, your team member says, okay, great, I can do it. It's not the case. ASPEN recommends that the co-administration of PN and medications should be supported by physiochemical compatibility and stability data. Honestly, that's a little bit of a pipe dream. I wish we had physiochemical compatibility data on most of the things that we have to give, but sometimes you're dealing with what you have, and most of the time I would say that I don't feel like I have a lot of chemical compatibility data when I'm assessing my IV compatibilities. There's wide variation in how many things are inconclusive, how many things are considered compatible across the literature. And again, that highly variable methodology makes it really hard to assess. When we started looking at aqueous compatibilities, this is an example. This is two drugs together, but the same thing exists for PN and drugs. I was begging time out of a lab in the School of Pharmacy, and it was a protein aggregate research lab. And so when I asked for the light obscuration instrumentation, they're like, well, we have it, but why would you use it? We use USP 788 with our light obscuration, but we also use flow imaging, and that shows us way more about what's actually in your fluids. So when we did our testing, we did flow imaging and background and membrane imaging. As you can see, light obscuration for this compound or this combination it's compatible. But when you look at the flow imaging results, we see vastly different particle count numbers. And so I don't know that we have a great understanding yet of what is actually in our solutions that we are infusing into our patients. That being said, even with the higher sensitivity, we did find that most of the medications that we're giving are actually compatible. So that is at least encouraging. And so when you look at the different types of protein that is mixed into the PN and how concentrated it is, that can vary how your compatibilities look. But in an overview, at least, we're seeing kind of the majority that are at least compatible, even with higher sensitivity metrics. So there's a bunch of different ways you can add medications to a PN. You can add it as an admixture. I would not recommend this. It is not well defined in terms of how many medications are actually even robustly tested in a way that is supportive of adding it to admixture. So there's a few things that we add, but most medications are not being added to PN at this point. When you're looking at 3-in-1 medication compatibility, so you're Y-siding it in with your 3-in-1 bag, you're held to the USP 729 standards, 5 microns and up, which is great. It's difficult to assess other particulate that's forming in that solution because the lipid emulsions are aqueous, or opaque, sorry. And the application to clinical practice is a little bit obscure. In pediatrics, we don't use as many 3-in-1s. It has more of a role in chronic PN, older patients, but they tend to be a little bit more dilute, which may be a boon for your compatibilities. In terms of 2-in-1 medication compatibility, so then you're looking at both running your PN and meds with 788 and looking at the 729 information for IV lipid emulsions and your medications. This is much more common, at least in my practice, and we have higher concentrations of nutrients, electrolytes, all sorts of things that kind of dictate that need. We have a higher risk of precipitation with every single medication that we add to that Y site. So you have to really think through what that looks like for your patient. And amino acid formulations, lipid emulsions, things like that can all play a role in how your compatibility can be assessed. If you're looking at a study, you need to note that Primusol is actually sort of the generic of trophamine. So the calcium and phos ratios and the solubility curves are very similar for Primusol. So take note of that. I don't know that that's widely known knowledge, but you can potentially extrapolate those pieces of information to your trophamine. If there's data with trophamine, you can extrapolate the Primusol. And then finally, IV lipid emulsions. So there's a lot of nuance here. There's not a lot of great information as to what we should be using, and almost no information about running IV lipid emulsions alone, although I will say in practice, we are often separating out our PN and our lipids into different lines in an effort to run and maintain a med line. So we also don't know what PFAT5 is appropriate for the patient. So is it 0.05? Is it 0.4? Is it somewhere in the middle? It's unclear. I think that's more clinical discretion than anything else. A great example of this is this example. So gentamicin, if you are applying USP thresholds, has varying compatibility. If you are applying Driscoll's threshold of 0.4, these are all compatible. Additionally, when we publish this, we publish the raw numbers. And the reason for that is because you see this AIT in that second column. That is not precedented. There's no research that shows that that has any sort of clinical impact. But what we're trying to arm you with is information, because if you're Y-siding this in with 4 other things, then you may want to know that that large globule fat tail is starting to increase with your gentamicin itself. Duplicate slide there. All right, so how do we assess PN components and compatibility? The take-home point is it's critical to assess the entire matrix that you're looking at, not just one item when you're assessing both stability and compatibility. And you really have to take a time to understand the methodology that's being applied to your studies to better critically and clinically assess what is going on and hopefully promote patient safety. Thank you.